Schizoaffective disorder is a chronic psychotic condition. Look at this picture, shows that split of mind and affect feeling and thoughts. Look at this. A detail going on. So, schizoaffective disorder is a complex mental health condition that involves symptoms of both schizophrenia and mood disorders, major depressive or bipolar disorder, because it lies at the intersection of psychotic and mood disorders. It can be difficult to diagnose and manage. Early identification and comprehensive treatment are essential for better outcomes. Definition: schizoaffective disorder is a chronic psychiatric condition characterized by the coexistence of psychotic symptoms along with significant mood episodes, either depressive, manic, or mixed. Psychotic symptoms must occur for at least 2 weeks without mood symptoms for the diagnosis to be made. Etymology: schizo comes from Greek word schizion, meaning to split, referring to psychosis or disturbance in thought. Affective comes from affectus, meaning mood or emotion. Thus, schizoaffective disorder refers to a condition involving both thought disturbances and mood disturbances. Epidemiology: prevalence approximately 0 to 3 percentage to 0.8 percentage of the population. More common in women than men, especially the depressive subtype. Onset typically occur in early adulthood. Lifetime risk is lower than that of schizophrenia but higher than bipolar disorder. Types: 1. Bipolar type involves manic or mixed episode, often with depressive episodes. 2. Depressive types involves only major depressive episodes alongside psychosis. Causes: multifactorial. There is no single known cause, rather, a combination of factors contributes. 1. Genetic predisposition. 2. Neurochemical abnormalities, dopamine, serotonin dysregulation. 4. Structural brain changes, ventricular enlargement, cortical abnormalities. 5. environmental stresses. 6. Prenatal complications. 7. Trauma or early life adversity. Risk factors. 1. Family history of schizophrenia, bipolar disorder, schizoaffective disorder, substance use, especially cannabis, hallucinogens. 3. Stressful or traumatic events. 4. Neurodevelopmental abnormalities. 5. Social isolation. 6. Poor coping skills. 7. Early onset mood or psychotic symptoms. Complications. 1. Functional impairment, work relationships, social functioning. 2. Increased risk of substance use. 3. Suicidal ideation or attempts. 4. Homelessness or financial instability. 5. Poor physical health conditions. 6. Relapse and hospitalization if untreated. Pathophysiology. Below is a clear step-by-step evidence supported pathophysiology of schizoaffective disorder based on established mechanisms shared across schizophrenia spectrum and mood disorders. Pathophysiology step-by-step process. Schizoaffective disorder does not have one single cause. Instead, it develops through a multi-stage interaction of genetic, neurochemical, structural, and environmental factors. Below is step-by-step progression showing how the disorder develops. Step 1. Genetic vulnerability. People inherit overlapping genetic risk factors that predispose them to schizophrenia and bipolar disorder. Many genes affect neurotransmission, neurodevelopment, and synaptic plasticity. What this means, the brain is biologically more sensitive to stress and more prone to dopamine, glutamate, and mood related dysregulation. Step 2. Early neurodevelopmental disruption during fetal or early childhood brain development. Subtle abnormalities occur. Influenced by genetics, maternal stress, infections, or both complications. Neural circuits involving the prefrontal cortex, hippocampus, and basal ganglia develop atypically. What this causes long-term changes that reduce the brain's ability to regulate thought, emotion, and sensory processing. Step 3 neurochemical imbalance begins. The following three systems gradually become dysregulated. 1. Dopamine excess triggers hallucinations and delusions. Striatal dopamine hyperactivity is a hallmark of psychosis. 2. Glutamate dysregulation. Reduced NMDA receptor function in hippocampus and cortex increases dopamine activity downstream. 3. Serotonin and norepinephrine imbalance contribute to mood symptoms, mania or depression. Step 4. Structural brain changes develop. MRI study shows that individuals with schizoaffective disorder have reduced gray matter volume, changes in prefrontal and temporal cortex, alterations resembling schizophrenia more than bipolar disorder. Results weaker connections for emotional regulation, executive functioning, and reality testing. Step 5 Stress and environment trigger symptom express. During adolescence or early adulthood, major stresses, trauma, substance use, social stress, cannabis use interact with biological vulnerability. They aligns with stress vulnerability model where stress activities abnormal neurotransmitter responses. Impact dopamine spikes, psychosis, serotonin, norepinephrine imbalance, depression or mania. Step 6 Psychosis and mood dysregulation co-occur because neural circuits for emotion and perception are closely connected. Their dysregulation causes symptoms, psychotic symptoms, dopamine excess, hallucinations, delusions, cortical connectivity dysfunction, disorganized thought, mood symptoms, serotonin, norepinephrine dysregulation, depression or mania, lymphatic system hyperactivation, emotional instability. Why they appear together? Shared circuits, prefrontal lymphatic pathways regulate both mood and reality testing. Step 7 Episode formation with repeated neurochemical instability. 1. Psychotic episodes emerge due to dopamine and glutamate imbalance. 2. Mood episodes follow due to lymphatic system and monoamine dysregulation. 3. Periods occur via psychosis persist even when mood symptoms stop, which is the key diagnostic feature. Step 8, Chronic core and functional impairment. Over time, recurring episodes cause further structural and functional brain changes. Cognitive domains such as memory, attention, and executive function may weaken. Summary flow chart: 1. Inherited gene, schizophrenia plus bipolar overlap. 2. Abnormal early brain development. 3. Neurotransmitter dysregulation begins. 4. Structural brain changes emerge. 5. Stress triggers dopamine plus mood system imbalance. 6. Psychosis plus mood symptoms appear together. 7. Episodes recur, chronic illness. 8. Functional impairment increases. Stages: although not formally staged, clinical course may include: 1. Prodromal phase, subtle changes in behavior, mood, and functioning. 2. Acute episode, clear psychosis with mood symptoms. 3. Stabilization, reduction of acute symptoms after treatment. 4. Maintenance, long-term management to prevent relapse. Signs and symptoms: psychotic symptoms, hallucinations, commonly auditory, delusions, disorganized speech, disorganized or catatonic behavior, negative symptoms, mood symptoms, depressive, persistent sadness, sleep disturbances, loss of interest, fatigue, suicidal thoughts, manic, increased energy, decreased need for sleep, elevated or irritable mood, risky behavior, preserved speech. Medical diagnosis: diagnosis is clinical or based on DSM-5 or ICD-11 criteria. 1. Detailed psychiatric interview. 2. Mental status examination. 3. Rule out drug-induced symptoms or medical conditions. 4. Lab test: CBC, electrolytes, thyroid, toxicology. 5. Brain imaging if needed to exclude organic causes. Nursing diagnosis: 1. Disturbed thought processes. 2. Risk for self-harm or suicide. 3. Impaired social interaction. 4. Ineffective coping. 5. Sleep pattern disturbance. 6. Self-care deficit. 7. Risk for violence. Medical management. Treatment usually combines 1. Antipsychotics first line. Example risperidone, paliperidone, olanzapine. 2. Mood stabilizers. Lithium valproate, carbamazepine. 3. Antidepressants. SSRIs, SNRIs for depressive symptoms. 4. Electroconvulsive therapy ECT for severe depression or treatment resistant cases. Nursing management. 1. Maintain safe environment and continuous observation if suicidal. 2. Therapeutic communication. 3. Build trust and reduce anxiety. 4. Monitor medication effects and side effects. 5. Promote self-care and ADLS. 6. Encourage participation in therapy. 7. Educate patient and family about illness and medications. 8. Support relapse prevention strategies. Treatment options. 1. Pharmacotherapy, antipsychotics plus mood stabilizers plus or minus antidepressants. 2. Psychotherapy. 3. CBT, supportive therapy, family therapy. 4. Psycho education. 5. Skill training. 6. Substance use treatment if needed. 7. Hospitalization during acute episodes. Psychosocial medicine. 1. Cognitive behavioral therapy CBT helps address distorted thoughts and improve coping. 2. Family psychoeducation involves family in understanding and supporting treatment. 3. Social skill training enhances communication and daily functioning. 4. Supported employment. Vocational rehabilitation helps regain work skills and independence. 5. Assertive community treatment ACT multidisciplinary team offering community based care. Prevention. While schizoaffective disorder cannot be fully prevented, risk can be reduced through 1. Early treatment or mood or psychotic symptoms. 2. Avoiding substance misuse. 3. Stress management and healthy lifestyle. 4. Strong and social support systems. 5. Adherence to treatment to prevent relapse. In conclusion, Schizoaffective disorder is a chronic but manageable psychotic condition involving both mood disturbances and psychosis. Early diagnosis, appropriate medication, psychosocial interventions, and supportive care significantly improve functional outcomes. With comprehensive management, individuals can lead productive and fulfilling lives. Thank you. Have a nice day.